I'll introduce you, then you
Great.
give your talk, and then in the end, we'll take questions and answers. Is that okay?
Yeah. Perfect.
Yeah. So, Mansi, shall we start?
Yes, go ahead.
So, good evening to all of you. Good evening to this webinars of FINE. We've got a very interesting lecture coming up today, and the speaker today is Dr. Larry Robinson, who's done a lot of work in neuromuscular medicine and rehabilitation. And the carpal tunnel index that we so often use is named after him, Dr. Robinson. So welcome, Dr. Robinson. And he's going to talk to us today about the ICU weakness. So thank you very much for talking to us today, Dr. Robinson, and we look forward to your talk. Over to you.
Well, thank you very much for having me. I visited for one of the FINE lectures a couple of years ago and really had a wonderful experience meeting everyone there and getting to know the city. So I really appreciate you inviting me today. I'm going to be talking about ICU acquired weakness. And normally that's something of interest, but in the days of COVID, when so many people are in the ICU for a prolonged period and quite sick, this will be even more prevalent as a cause of disability and weakness than it was before. So I think of it as a more timely topic than it would be usually. So the goals of today's talk are to talk a little bit about the epidemiology, how frequent it is and how prevalent it is. Talk a little bit about the diagnosis of ICU acquired weakness, and primarily focusing on the myopathy, critical illness myopathy, and critical illness polyneuropathy. Talk about the electrophysiology and other testing that you might run into. Talk a bit about risk factors, and I wish we knew more about the risk factors than we do, but we know some. Talk a bit about the pathophysiology. Talk about prevention, and there's some interesting data coming out on prevention of acquired weakness, and then talk a little bit about treatment. So, and I've sent my slides ahead of time, and Sudhir, if you want to distribute those, that's fine. These have all the key references. So epidemiology, it depends a little bit on who's being studied and how you do the study. So the incidence varies depending on the patient population and the timing of the evaluation. If you look at weakness at awakening after an ICU stay, that's present in between 26 and 65% of patients who are mechanically ventilated for 5 to 7 days. For those who, roughly 25% of those remained weak for at least 7 days after awakening. So this is a prolonged weakness. Among long-term ventilated patients, and we'll count more than 10 days as long-term, ICU acquired weakness was diagnosed in about 2/3 of those folks. So the longer time that you're on the ventilator, the greater the risk of ICU acquired weakness. And that's a pretty frequent finding. So the detection of ICU acquired weakness, it's not a simple matter. It can be detected clinically by your manual muscle strength test, your MRC or Medical Research Council scale, which, as you all know, goes from 0 to 5. And although strength testing, your clinical testing, can identify weakness in up to 25% of patients who are ill, a minority of these patients are awake enough to participate in testing. And if they're not awake, it's really hard to detect weakness. You can't really detect weakness on your physical exam. So that's a deficit in identifying those with ICU acquired weakness or identifying the prevalence. It's challenging in the ICU to identify patients who are awake and cooperative. So if you look at the ICU patients, about 3/4 are unable to participate in real strength testing because of coma, because of delirium, because of traumatic injury, if it's a traumatic event. So you won't be able to really accurately identify those patients. The other problem, and those of you who do strength testing regularly and record the MRC scale, which is probably all of you, is the inter-observer variation. So if you look at experienced physiotherapists, who are probably more reliable than we are as physicians, experienced physiotherapists in inter-observer agreement, it's only a kappa of 0.6, which is okay, but it's not great inter-observer agreement. And for any of you who have done a retrospective study looking at the strength in patients, you'll see there's a wide variation. The same day, one physician will say it's a 4, the other physician will say it's a 2. So this is not an extremely reliable scale. Now, if you look at just the cooperative patients, those who are awake and alert and cooperative, the MRC testing does better. And if you have experienced physiotherapists, there's an interclass correlation coefficient of 0.95. But physicians don't do as well as physiotherapists who have a really set protocol. We're just not as good at inter-observer reliability. So that is another risk of detection, is that we're just not as good on strength testing. There are some potential biomarkers that could be considered. If you could perhaps have a biomarker that's helpful early on, you could have novel therapies directed to those patients who may be at risk. The creatine kinase, which is what we often use in muscle disease, that may be increased in patients with ICU-acquired weakness, but it's not a great biomarker. Other things that have been looked at are plasma levels of neurofilaments, which are biomarkers of axonal injury. Those are elevated in patients with ICU-acquired weakness. Peak neurofilament levels do show good discriminative power for weakness, but these peaks only occur after patients are clinically evaluable and really don't allow an earlier diagnosis. The diagnosis of critical illness myopathy, or CIM, and critical illness polyneuropathy, or CIP, that's best done with electrophysiologic testing to demonstrate reductions in motor and or sensory responses. That's the best way to really pick these folks up. You can do considerable testing, but usually we're thinking about one motor and one sensory nerve conduction study. That's what's typically done in a lot of ICUs across the world. So I know some of you do EMG, and this next little part will be very basic, and others maybe don't do EMG. So I just wanted to go through these. So the fibular motor, or perineal motor as it used to be called, extensor digitorum brevis, is a common motor nerve conduction study, and that is impactful to predicting who's going to have ICU-acquired weakness. You can also record from the tibialis anterior if you want to. So fibular motor to one of these two muscles. And the sural sensory response is the other nerve conduction that's commonly done. So this is how we would do the fibular motor to the EDB. We would stimulate the motor, the deep fibular motor over here at the ankle. We can also stimulate at the fibular head. We'd record from the extensor digitorum brevis, or EDB muscle, and we'd look at the size and the latency of the response as you record from EDB. And that's a fairly reliable study. And this is what you might typically get. Here we have a fibular motor response from EDB in a normal, this is a normal individual, stimulating at the ankle, stimulating at the fibular head. You can see it, of course, takes longer from the fibular head than it does from the ankle, and then stimulating up at the popliteal fossa. You can see amplitudes here are in the around 5 to 6 millivolt range, which is normal. Over 2.6 would be normal for us. And the duration is fairly short. And we're going to come back to duration in a moment. 5.5 milliseconds for the duration of time from the start to the finish of the negative peak. That's a normal duration. Normal would be under 9 milliseconds for this study. If you have a fibular motor response, think about the size of the CMAP, the size of that motor response as being proportional to the number of functioning motor units. So how many axons you have, how well the neuromuscular junctions are working, and how many functioning muscle fibers you have. And if the response is reduced in amplitude, it's a small response, there must be a problem with one of these. So it might be that you have fewer motor axons. It might be that you have an abnormality in the neuromuscular junction, or perhaps you lost muscle fibers. Any one of these would give you a reduced amplitude response. So a reduced amplitude response can be seen in critical illness myopathy or neuropathy. That is, you've lost muscle fibers or you've lost axons. Either one can produce a small amplitude response. Now, one thing that's kind of curious is that if you have critical illness myopathy, not the neuropathy, just the myopathy, people observed very long duration CMAPs in those patients. As I mentioned, for the EDB response I showed you earlier, the duration was about 5 or 6 milliseconds. Up to 9 is fine. And in the tibialis anterior, up to 15 milliseconds is fine. This is an example from someone with critical illness myopathy. So here we're recording from tibialis anterior, where normally we have a duration of no more than 15 milliseconds. But this guy, it's 29 milliseconds. It's a very long duration CMAP. This should be under 15. And the amplitude is very small, 0.2 millivolts. This is less than 10% of the lower limit of normal. So this is a interesting finding that we really see primarily in the critical illness myopathy, not in the neuropathy. And when we see this, we're thinking this is primarily a myopathic kind of issue. The sural sensory response is the other nerve conduction we commonly do. And here we stimulate the sural nerve in the leg and record at the lateral foot. And this is just the sensory axons. And the amplitude reflects the number of functioning sensory axons. So if you lost sensory fibers, you would have a smaller amplitude response. Now, if we have a small amplitude response, that could be seen in a polyneuropathy, but a pure myopathy, a pure critical illness myopathy, should not affect the sensory fibers. Those should be fine. And so that's a way to start to differentiate the critical illness myopathy from the neuropathy. Again, we talked about the fibular motor response not being specific necessarily for critical illness myopathy or neuropathy. And remember that the sural response is not abnormal only in critical illness polyneuropathy, but other neuropathies as well. These are fairly small responses, so those of you who do nerve conductions will recognize that it's tough to do in the setting of marked edema, and many of these patients do have quite swollen legs, so it's hard to record these. This is a typical sural sensory response. This is time going across the x-axis and voltage on the y-axis. And here we have a normal response of about 6 microvolts. Normal would be over 5 microvolts, and a normal latency of 3.5 milliseconds. Normal would be under 4.1. So this would be a normal response. And if we had a small amplitude or absent response, that might be what we would see in a critical illness polyneuropathy. So as we think about the two diagnoses, polyneuropathy versus myopathy, the critical illness polyneuropathy would have small amplitude motor responses and smaller absent sensory responses. Both of these would be affected. In the critical illness myopathy, you would have small amplitude motor responses, long duration like that recording I showed you, but normal sensory responses. The myopathy would not affect the sensory responses. So that's how we start to differentiate these two. In actual fact, and we'll come back to this later, many patients have both of these at the same time, and it's not purely one or the other. Now, remember, there are many other entities that cause these changes as well. So other polyneuropathies, neuromuscular junction disorders, like we said, can affect the motor responses. Other myopathies or motor neuron disease can also affect the motor responses. So if you see abnormalities in critically ill patients, you don't want to just automatically assume it's a critical illness weakness. It could be other diseases that got them there in the ICU in the first place. Now, how good are nerve conductions for detecting ICU-acquired weakness? At least one study has looked at this, and the sensitivity is quite good. We're pretty good at detecting, and they could lump the two together, neuromyopathy, and the specificity is also reasonably good, 81%. So this is not a bad study. It's probably the best thing we have, better than any serum markers for detecting ICU-acquired weakness. I just want to talk about needle EMG for a moment, and this will, again, we'll take a little bit of detour to the basics, and then we'll come back to the EMG findings in these patients. For those of you who don't do EMG all the time, this is a diagram of a normal motor unit. We have the anterior horn cell or motor neuron cell body here, the axon, and then all the muscle fibers that it supplies in this model. And the number of muscle fibers varies with the muscle. With a very finely controlled muscle like your extraocular muscles, your laryngeal muscles, you might have only 4 to 6 muscle fibers. But for the quadriceps, where you need a lot of force, you may have 1,000 muscle fibers supplied by one axon. When you give a small voluntary contraction and have a needle in these muscle fibers, you can record a motor unit action potential, MUAP, or motor unit action potential. And this guy represents the synchronous discharge of all these muscle fibers that are supplied by the single axon. And this is just another diagram. This is the axon, all the muscle fibers supplied by the axon. And then you have a needle in there that records from a finite volume of muscle. When the muscle contracts, you get a normal motor unit action potential that looks something like this. And we have normal values for the size, for the duration, for the number of phases here. If you have denervation, and this could be from a polyneuropathy, like critical illness polyneuropathy, or other causes, then these muscle fibers, these little muscle fibers here, they'll start to fire on their own. These are spontaneous single muscle fiber discharges. We think this is related to acetylcholine hypersensitivity of the muscle fiber and instability of the muscle membrane. And these single muscle fiber discharges are exhibited as fibrillations, which kind of look like this, or positive sharp waves, which have a distinct positive waveform. This would be what a fibrillation looks like, and this is what a positive sharp wave would look like. And these, again, are single muscle fiber discharges, not the whole motor unit. And then if you had reinnervation, if you had, say, a partial injury where one axon was killed, the other guys are okay, then this axon, this motor unit says, you know what, I know there are some denervated muscle fibers out there. I'm going to try to save those muscle fibers. I'm going to send new sprouts out and reinnervate those denervated muscle fibers. And these new sprouts come from the distal axon terminal or from the distal nodes of RON-V8, and they reinnervate these denervated muscle fibers. And we know that because when this guy fires, he doesn't look the same as normal. His new sprouts are polymyelinated. They don't synchronize as well. And the motor unit becomes larger in amplitude. There are more muscle fibers supplied, more polyphasic because they don't synchronize as well, and also a longer duration from start to finish, again, because of the poor synchronization, also the total number of muscle fibers in the unit. So that would be a sign of reinnervation that's occurred, which is a little bit more chronic. Now, we talked about positive waves and fibs in denervation. It's not specific to axon loss, unfortunately. And if we think about a myopathy, in many myopathies, you'll get what we call segmental necrosis. And so with segmental necrosis, you'll see some normal muscle fiber, then you'll see a necrotic area. Then there's a part distally over here, which is functionally denervated. It no longer has the supply from its axon. And so when that happens, this gray area will start to fire on its own, and that will also be exhibited as positive sharp waves or fibrillations. So positive waves and fibs, not just seen in denervation, but also seen in myopathies. The myopathic motor units, they look different from the neuropathic motor units. In this same model, let's say we have a few of these muscle fibers that have died off. Well, if you have less muscle fibers, you're going to have a smaller amplitude motor unit. It'll also be shorter duration because reduced number of muscle fibers. And it may be polyphasic because the muscle fiber conduction is not normal and they don't all synchronize as well as they normally would. So these would be myopathic motor units. So let's just come back to the critical illness myopathy. So in that setting, electrophysiologic testing, as we talked about, shows reduced amplitude CMAPs with preservation of sensory responses. And then you will see some fibrillations for the reasons we just mentioned because of that muscle fiber necrosis. If the patient can participate and can give you just a few motor units, and frankly, a lot of times they can't, they're sedated, they're not really awake and alert enough to do that, then you may see some of these myopathic small amplitude motor unit action potentials. But you just can't count on that. It doesn't always work that way. They can't really recruit well enough to give you a good motor unit analysis. In the critical illness polyneuropathy, that's where you'll have a symmetric distal sensory motor axonal neuropathies. These are primarily axonal, not demyelinating. They can affect, of course, the distal limb muscles. Now, often if we're electromographers, we'll get called to the ICU to say, I can't get this guy off the ventilator. And it's perceived as a respiratory muscle weakness, but in fact, all the limbs are weak, and it's not just the phrenic nerves that are weak, it's all the limbs. And it can also affect sensory and autonomic nerves. In this setting, the electrodiagnosis demonstrates abnormal both sensory and motor responses, and the needle EMG shows fibrillations and perhaps reduced recruitment of motor units, reduced numbers of motor units, and the guys who are there are firing faster than normal. So are these two separate entities? I think it's increasingly recognized that both the critical illness myopathy and polyneuropathy are not necessarily purely distinct entities. And unfortunately, many patients have both CIP and CIM at the same time. And we think of this now as an overlapping spectrum triggered by an overall acute inflammatory response, often occurring simultaneously. They're probably both there at the same time. So let's just talk a little bit about risk factors for ICU-acquired weakness, and then we'll talk about treatment as well, prevention and treatment. So there are risk factors pre-hospital, before they ever got sick and came in the hospital. There are disease severity risk factors, and then there are treatment risk factors. So pre-hospital function, if you look at actually analysis of patients' pre-hospital functional data who are subsequently admitted for severe sepsis, many of the symptoms of the post-ICU syndrome, the weakness, were present before admission. So if you have an elderly, frail person with multiple comorbidities, they may actually have sarcopenia and weakness before they ever got in the hospital. And you have to take that into account as you're thinking about ICU-acquired weakness. And accounting for the pre-hospital functional trajectory appears to help define the care trajectory after critical illness. So if they were getting weaker and sarcopenic before they ever got to the ICU, that may actually continue to progress. So the data that are out there highlight the increasing recognition that pre-hospital function informs what's going to happen in hospital and post-hospital impairments. So this may account for some of the variants in phenotypes that we see and how people respond differently to intervention. Here's a reference. And like I said at the beginning, I think I've given Sudhir my slides, so all these references will be available to you afterwards. Let's talk a little bit about the disease risk factors. So despite dozens of studies, and it's beyond dozens right now, looking at clinical risk factors for ICU-acquired weakness, there's not a complete certainty over which factors are truly causal, which ones really cause ICU-acquired weakness. The most consistently implicated risk factors are those associated with severity of illness. So shock, sepsis, degree of multi-organ failure. We have pretty good agreement that those are strong risk factors. The severity of illness is probably your strongest risk factor. So this would help to support the premise that ICU-acquired weakness is actually, it's just another manifestation of multiple organ dysfunction. Cohort studies in patients who are critically ill show an association between sepsis and ICU-acquired weakness in unadjusted analysis with odd ratios between 2.9 and 49. So depending on the studies, if you have sepsis, you have between a 3 and a 50-fold risk factor for ICU-acquired weakness. That's a strong association, sepsis and ICU-acquired weakness. And here again is the study that's looked at that. So sepsis, clearly a strong risk factor. Now, treatment risk factors, that's where it becomes more nebulous and more uncertain. There are a number of ICU interventions or exposures identified as potential risk factors for ICU-acquired weakness. So administration of corticosteroids has been looked at, and we'll talk about each of these in a bit. Neuromuscular blockade has been looked at, poor glycemic control, aminoglycosides, and immobilization. Those are all potential risk factors. There are conflicting data on the associations between corticosteroid use and neuromuscular blockade with ICU-acquired weakness. it's not really as clearly a risk factor as we initially thought. And part of the problem is that the overall effect of corticosteroids on acquired weakness remains uncertain and difficult to ascertain because of indication bias, high variability in patient phenotypes, and steroid dosing. So the sickest people are going to be more likely to get steroids. They're the ones who are also likely to get ICU-acquired weakness. And the steroid dosing is not consistent. It's not like everyone gets the exact same dose of steroids. So little unclear what the contribution from steroids is. Pathophysiology of critical illness polyneuropathy. There are a number of theories, and maybe some of you on the call will have more knowledge of this than I do, but still, as far as I can see from the literature, not completely certain what the pathophysiology is. There are some questions about whether it might be loss of the blood-brain barrier as part of it, perhaps inexcitability of the endoneurial membrane, perhaps a direct toxic effect from ICU therapies, including hyperglycemia or lipids in the parenteral nutrition. We're not really certain of the underlying pathophysiology at this point. Critical illness myopathy, we're in sort of a similar state. The histologic study of muscle biopsy specimens demonstrates atrophy. There's a preferential loss of thick filaments, which reflects myosin loss and muscle necrosis. And again, we have some proposed theories, which includes chemokine-induced autophagy of muscle membrane inexcitability, channelopathies, or again, a direct toxic effect of ICU care. But unfortunately, we don't really know for certain the underlying pathophysiology behind this. Let's talk a little bit about prognosis. So this is not a great prognosis. Once you get ICU-acquired weakness, you don't have as good a prognosis for making it out either alive or well. So here's a propensity matched cohort of patients who are critically ill. Here they defined ICU-acquired weakness using the MRC scale, those who are weak on clinical examination. If you were weak, you had a 30% lower likelihood of just being alive at hospital discharge. So that's a significant drop in survival. And even at 1 year after, if you were discharged, you had a 13% increase in mortality at 1 year. So these people who have ICU-acquired weakness, at least defined by the MRC scale, they are a group of sick people who have a lower likelihood of being discharged alive and a higher likelihood of dying in the first year. So this is a reflection of bad disease. In another study, patients receiving mechanical ventilation who developed ICU-acquired weakness had a lower physical functioning health-related quality of life, the SF-36. So the physical functioning score on the SF-36, they had 45 if they had ICU-acquired weakness versus 75 if they did not. So that's a significant drop in the physical functioning score. Higher strength scores were associated with a higher physical functioning score. And if you look at the decrease in the PFS, ICU-acquired weakness was associated with a 16.7 point decrease. So those who have ICU-acquired weakness do have a significant lower physical functioning after discharge. It's really not a good prognosis that way. Is there a difference in prognosis between the two? There is some data, and it's a little hard to interpret because they're, again, not completely distinct entities, that the myopathy has a better prognosis than the polyneuropathy. But again, there's considerable overlap between these two. We don't always have just one diagnosis. Now, what about subclinical disease? Are there people who have ICU-acquired weakness that you might just not pick up because of all the difficulties with detection? This is one study looking at 730 patients with respiratory failure without weakness. So didn't have observed weakness in the ICU. And they did the fibular motor study to EDB that I mentioned before. And if you had an abnormal CMAP, compound muscle action potential, on day 8, that was associated with a higher 1-year mortality, 48% in the groups with the abnormal mortality in the groups with abnormal CMAP versus 29% in the groups with a normal CMAP. So even if you don't detect weakness in your clinical exam, if you have a small or absent CMAP, then you have a higher risk of mortality at 1 year. So this seems to be fairly predictive for people who are going to do poorly by doing that fibular motor response. Let's talk a bit about prevention. And there are actually ways to prevent this. There is a building literature regarding early exercise to maintain muscle strength and improve function in patients in the ICU. There are prospective cohort studies in patients with acute respiratory failure that show that mobility in patients receiving mechanical ventilation is safe, feasible, and associated with reductions in length and stay of mortality. By mobility, and this is hard to believe, but what people have done is while you're on the ventilator, get people awake enough to actually stand and take a few steps. The nurses don't like doing this at all. They get very nervous and it takes a lot of nursing time, but this is what's associated with a prevention of ICU acquired weakness. There have been multiple studies on this, and that simple step seems to be preventive. There was a randomized controlled study in patients performing activity through physical or occupational therapy within 48 hours of respiratory failure. And they showed that by doing this, you had an improvement in ADL independence, 60% versus 35%, and a greater walking distance at hospital discharge, 33 meters versus 0 meters on average, and a very significant difference here. And this is a randomized study. So it looks like having people stand up and take a few steps while they're on the ventilator is quite effective at prevention. And here's the reference if you wish to look at it from Lancet. Now, there have been multiple RCTs looking at early mobilization, and it looks like it's an effective treatment for ICU-acquired weakness. That is, if you have an early mobilization, your odds ratio of getting ICU-acquired weakness is only 0.27. It's about 1/4 the chance if you have mobilization to get ICU weakness than if you didn't mobilize. So this seems to be an effective prevention for ICU-acquired weakness. Now, it is hard to get people out of bed when they're ICU and they're on a ventilator. So the question came up, could you do neuromuscular stimulation, electrical stimulation? And recent systematic review, and there's been multiple studies on this, says, you know what, it's probably not effective at preventing ICU-acquired weakness. Don't really know why. It may be the standing, and maybe there just doesn't get enough muscles working. I don't really know. But there is no significant difference between neuromuscular electrical stimulation and usual care on any of these measures: strength, mortality, duration of mechanical ventilation, or length of stay. So while we would have hoped that stimulating muscles would get us there, doesn't look like it does, unfortunately. And there's some nice meta-analysis on this. Now, just in terms of ICU care, the routine features of general care provided in the ICU have traditionally included liberal use of sedation and immobilization of the patient. Just easier to have them asleep and in bed, not moving. That was easiest for the team. And we also thought that this was necessary for facilitating interventions to normalize physiologic function by artificial means. We'll just watch the numbers, get everything in good physiologic range. But recently, there's been a paradigm shift away from this approach to more of a less is more philosophy for patients in the ICU. That is, let's do less sedation, maybe a little bit more mobilization, and that would be more effective. Now, let's talk a little bit about treatment. Once patients have developed ICU-acquired weakness, it would be of use to know which interventions are most likely to restore previous function. So the exact type of rehabilitation interventions required to reduce impairment, maximize functional independence, and improve health-related quality of life, not yet well understood. We don't know exactly which rehabilitation is going to be most effective. To date, there have been limited studies to evaluate intensive inpatient-based and outpatient rehab programs. So we're reaching the end, and a few just take-home points that I'd like you to remember. Then we'll go to the Q&A, and please submit your Q&A in the Q&A box on Zoom. ICU-acquired weakness is very common. Remember that up to 2/3 of people will have this if they've been on the mechanical ventilator. Our ability to detect ICU-acquired weakness is suboptimal. Measuring strength in the ICU is challenging primarily because of patient sedation and cooperation. Probably our best test is to do nerve conductions, fibular, motor, and sural sensory responses. Risk factors to think about: pre-hospital function. Think about pre-hospital function, and that's going to help establish the trajectory post ventilation. Disease severity is your primary risk factor. The sicker you are, sepsis, the longer you're on the ventilator, those are going to be the primary risk factors. Maybe steroids, maybe neuromuscular blockers, maybe glycemic control. Those are more questionable than the first two. So those are maybes. The pathophysiology, unfortunately, is not completely understood, but we do know that early mobilization and less sedation are likely preventive and may be helpful to prevent ICU-acquired weakness. Other treatments less clear. We don't think that neuromuscular electrical stimulation helps. I didn't mention this earlier, but we don't think bicycle ergometer in bed helps. You really have to get up and do some walking. If you're looking for review articles on this, and this is a constantly evolving field, these are 3 good review articles to take a look at in the literature. I do think we're going to be seeing more of these patients as we have more COVID patients coming in the ICU. So let me stop there, and I'm glad to take questions if that's good. Let me go to the Q&A box. Is that okay, Sudhir, if I take questions at this point?
I think, first of all, thanks very much for a very nice and informative talk. And Dr. Rakesh Singh is with us, and he's going to take us through the question and answers. So he will put the question up and then you can answer it.
Okay,
Sounds
yeah. Great.
Rakesh, you want to take over?
Yes, sir. I will take the questions. Can you hear me, sir?
Yep.
Yeah. Okay.
Yeah.
So I'll just put on. There are few questions. How frequent is myositis ossificans seen in patients with critical illness myopathy?
I don't really have a number. I have to say I haven't seen it myself. I haven't seen it myself. So if it occurs, I don't think it's particularly common, with the exception that there are some patients. So for instance, burn patients who have been in the ICU, burn ICU for a while, they are more likely to see myositis ossificans or heterotopic ossification. So that would be it, but that might be a different sort of risk factor than the critically ill.
Maybe after, typically after fracture neck femur in that limb we see, I mean, diffuse myositis of ossificans is a little unusual.
Yeah, that's
inflammatory myopathy you see, dermatomyositis.
Okay.
Yeah. Yeah, I don't think you see it in this group too commonly, though. And you're right, in the traumatic injury, that's right. If you have a traumatic injury to the muscle, you could certainly see that too.
Then, sir, how long one takes to develop CIM or CIP after admission in the
yeah, it's a good question. I wish I had a better answer to this because it depends on the severity of the illness and perhaps on the pre-hospital trajectory, how weak you were and how many comorbidities you had before you came in the hospital. It's in the range of days. It's not weeks or months. It's in the range of days. But I don't know that we have a great handle on how many days it takes.
And sir, does the time of onset depends on certain factors?
Yeah, I think if you have sepsis, you have multi-organ failure, if you came in weak and frail, that it's more likely to develop earlier. But I don't know that there's great data on that. Maybe the other, Satish, you may know, or Sudhir, you may have some information on that.
I would say,
but it's in the days range.
Would you agree that generally it would parallel the course of the sepsis? So if the person goes into multi-organ failure, the weakness also would happen at that time. You won't have the multi-organ failure improving and then critical illness developing later when the person is improving, not like GBS or something like that.
Right, right. No, I agree. That's a very good point. It would parallel the course of the disease.
Then, sir, what is the role of passive exercise in preventing critical illness neuropathy?
Yeah, because it's a great question. Because it's so hard to get these patients standing and walking when they're on the ventilator, it would be great if there was something easier we could do that would substitute and also prevent ICU-acquired weakness. But I'm afraid we don't have such a thing. And so passive exercise doesn't seem to be preventive. Having a bicycle ergometer in bed where people sort of rotate their legs, that doesn't seem to be preventive. Like I said, neuromuscular stimulation, no. So I don't think passive exercise would prevent the neuropathy. Now, of course, it might be useful still to prevent contractures and might be helpful in other ways, but I don't think it prevents the critical illness.
And so there is a question, would vigorous passive therapy exacerbate myopathy?
Not that I know of. Not that I know of. Now, of course, if you have super vigorous stretching, could you perhaps get some muscle injury? I suppose you could. But I think just your sort of normal range of physiotherapy, nothing I know of would be a risk factor.
Larry, what is the most severe grade of weakness that you have seen? I mean, do you get neck flexion grade 2 or something like that? Usually neck flexion is not affected. Or what about dysphagia or dysarthria or diplopia? I mean, those cranial nerves probably would not get affected.
I haven't seen the cranial nerves affected as much. I think neck flexure sometimes, yes. One of the downsides is they're not great at doing a manual muscle test exam. So it's not always possible to get an accurate measure, but I tend to see the limb muscles more affected. And then also the ICU docs say, hey, we can't get this guy off the ventilator. So the respiratory muscles would be affected as well. But I haven't seen that much in the cranial nerves being affected. I think that's much less common. Is that your experience also?
Yes, absolutely. Yeah.
Yeah.
Then, sir, there is a question, do neurosurgical patients like head injuries who do not have septicemia but remain in the remain in the ICU due to being delirious develop ICU acquired weakness?
I haven't seen that as commonly. So patients say acquired brain injury, traumatic brain injury, or aneurysm, those kinds of neurosurgical patients, if they're in the ICU, but they're not septic, they don't have organ failure, they're not sick in other ways, I don't see them as commonly as having ICU acquired weakness. It's primarily the sepsis and multi-organ failure. Those are the big risk factors.
Similarly, probably in the cardiac ICUs, you don't see it so often.
Yeah, I agree. In the cardiac. Now, of course, if they develop an ARDS-like syndrome, that's a risk factor. But yeah, pure cardiac disease with otherwise healthy, not so much.
I found most of the time the reference doesn't come because the person is weak, because that is accepted that he's going to be weak. But it happens when they try to get the person off a ventilator and they can't get him off a ventilator, and then the reference comes to the neurologist that has he got something.
Yeah, that's a really good point. Is that we'll get contacted to say this guy isn't coming off the ventilator. Maybe there's a phrenic nerve injury. So could you study the phrenic nerves? And so you don't want to. So don't go down that pathway of having sort of a myopic view of just phrenic nerves and just the diaphragm. Take the whole, take a look at the whole patient to see if it's a widespread neuromuscular problem rather than just phrenic nerves. Now, of course, they don't move anyway. So if they're sedated, so it won't be apparent that they're weak in the limbs. And so I understand why the ICU doc is asking that, but and you all know this, but just take a wide look.
Sir, how to differentiate GBS from CIP?
Yeah, great question. So how to differentiate the Guillain-Barré or AIDP from a critical illness neuropathy? The critical illness neuropathy is primarily an axonal neuropathy, axon loss. And you don't really get much in the way of demyelination. So in the critical illness neuropathy, you'd see small amplitude or absent sensory responses. Same thing for the motors, but the responses, when they're present, they would be a normal velocity. You shouldn't really see conduction block. You shouldn't see prolonged distal latencies. In the Guillain-Barré or AIDP, that's primarily a demyelinating neuropathy. So what you would see there that would trigger your thought, you'd say, oh, gee, the latencies are very long. The velocities are, show a marked patchy slowing. I can't get F waves. I have conduction block. Those would be the hints for Guillain-Barré. As the question suggests, really important to differentiate those two because you would go down a different pathway if you had GPS in terms of treatment.
And sir, how often you see isolated myopathy or the neuropathy? Isolated ones, pure.
Yeah, isolated one. I wish I could give you a good answer on that. And the problem is that once you have, say, a critical illness polyneuropathy, as we talked about before, you would have small amplitude motor and sensory responses. They would already be small. So could you detect a myopathy on top of that? That's a tough one to know for sure that you also have myopathy. There are some techniques to do direct muscle stimulation, which might help you. But it's relative, at least in my experience, occasionally we'll see a pure myopathy where the sensories are beautiful and the motor responses are small. That's a relatively smaller percentage of the total. I don't have a number. And sometimes you'll see what we think is a pure polyneuropathy, but frequently they're coexisting. When we do see the pure myopathy, when the sensories are great, but just the motor responses are small and long duration, that's probably a bit of a better prognosis, that you're going to do better prognostically than if you had the polyneuropathy, which is a worse prognosis.
Sir, how do you do the nerve conduction and EMG test? Do you do it at the bedside or you ship the patient to the lab?
Yeah, these people are very sick. They're on the ventilator and it's really hard to move them. So we typically bring the EMG machine up to the intensive care unit and do the nerve conductions there. Of course, there are technical issues with doing that. You have a ton of 60 cycle artifact in the ICU. So you have to be very meticulous about your technique, cleaning off the skin, put your machine on the opposite side of the patient as all the machinery is, plug into a different plug that's not, have other stuff plugged into. One little trick, if you're doing needle EMG that not everyone knows, is if you're getting a lot of 60 cycle on your needle EMG, that's usually because of impedance mismatch. You have a surface reference, which has one impedance, and a needle in the muscle, which has a different impedance. And when those two are different, it'll accentuate the 60 cycle. So if you have a second needle to use as your reference, put that just under the skin, then that impedance is matched with the active needle, and you'll get rid of a lot of the 60 cycle that way. But we do go to the ICU. It's just too hard to get the patient to come down to the lab.
So then there is a question that in critical illness myopathy, the CMAP durations are classically prolonged. Their duration of that graph is actually prolonged. What is the reason for that?
I wish I knew. It has to do, I think, with the muscle fiber membranes and the slowing of conduction of the muscle fiber membranes, I think. But I don't really know for sure. I know empirically that's what we see is a very long duration CMAP. Maybe Satish or Sudhir, you might have some thoughts on why you get a prolonged duration CMAP. No, okay. But that's what you see. So if you see that, small amplitude, very long duration, think, oh, that's really strange. That's more likely critical illness myopathy.
Yeah. So is there a link to B12 deficiency, underlying B12 deficiency, and which can precipitate the ICU-acquired weakness? Are there any studies where B12 levels were assessed in patients of ICU-acquired weakness?
I don't know of any linkage between B12 deficiency and ICU-acquired weakness. Of course, B12 deficiency can create its own polyneuropathy. You can certainly get a polyneuropathy from that. Tends to affect sensory fibers more than motor fibers. So that could be a cause on itself. But I don't know of any studies that suggest B12 deficiency would be a risk factor.
And the presentation is also predominantly motor rather than sensory, which you would have in B12. But there is some link of vitamin D or in the myopathy part of it.
Not that I know of. Again, the literature is constantly evolving, but I don't know of the link with vitamin D. It's a good point that in B12, you would have primarily sensory symptoms. Of course, it may be hard to tell in the ICU. They're not going to wake up from their sedation and complain of numbness. You just won't know that they have sensory loss. The motor weakness is what's most the biggest manifestation.
Sir, is there a way to mobilize the diaphragm? You know, like we say that if you do early mobilization of limbs, it can actually, the outcome can be better. So is there a way to mobilize diaphragm, you know, by changing the ventilator settings? Do you have any advice for that?
I don't know that there's a great way to mobilize the diaphragm like there is in the limbs. Unfortunately, I don't know of a way to do that. There are ways that have been described to exercise the diaphragm, but you have to have enough voluntary activity to be able to exercise against resistance. So some people years ago have put, say, a weight on the abdomen and have a person breathe in against the weight, and that would do some diaphragmatic strengthening because you're pushing the abdominal contents down. But in these patients, they're so weak. You know, if you can't, if you don't generate enough force to breathe, you're not going to be able to push against resistance, unfortunately.
Is there a role of lumbar puncture to differentiate acute motor sensory axonal neuropathy versus CIP?
Acute
lumbar puncture to differentiate between CIP and
I think the lumbar puncture might help you if you're thinking about, say, Guillain-Barré, like we talked about before. That would help you diagnostically there. I think in the absence of that and the differential diagnosis, I'm not sure it would help you that much. You could probably see, you know, if Guillain-Barré is in the differential just from your nerve conduction studies. And if you have suggestive findings there, then it may be worth doing lumbar puncture. But in the absence of demyelination, and again, I would look to Sudhir and Satish to see if you have thoughts. I don't know that it would be that helpful.
As you said, the nerve conduction would be less invasive, and in a person who's critically ill and who's on a ventilator, you don't really want to do a lumbar puncture. So I don't think it's...
So there are two questions on
Satish,
role
what do you think, Satish?
Sorry?
What do you think about lumbar puncture?
They hardly ever used it. Most of the time, your clinical presentation, your electrophysiology data will tell you where you stand. Only occasionally. Yeah.
Right. Okay.
Then, sir, there are two questions on muscle ultrasound. How useful it is to detect the muscle, basically wasting, atrophy. Use of muscle ultrasound.
Yeah, I wish there was a good answer to that. There are some studies looking at muscle ultrasound, also near infrared spectroscopy of muscle, where basically you're shining an infrared light into the muscle and picking up the reflection. Those may be abnormal, both ultrasound and the infrared spectroscopy, but I don't think they add much to the, it's still in the research mode. It's not really used clinically as far as I can tell. And I don't think they add much beyond doing your conventional nerve physiology. I don't think it adds sensitivity. They might be abnormal there, but I don't think it would really add anything to the diagnostic decision-making.
So then, do we have a study where they have assessed different causes of septicemia? With the incidence and extent of ICU-acquired weakness, comparing different causes of septicemia in causing ICU-acquired weaknesses.
Yeah, I wish there was as uniform as we'd like, but people come into the ICU through many different pathways. And so many different underlying diseases, many different causes of sepsis. And as far as I know, there really hasn't been a great way to get a pure cause of, say, urosepsis, that's a higher risk factor than, other causes of ARDS or whatever. So I don't think we're down to that level where we can say one cause of sepsis is a higher likelihood than another. We're at a grosser, higher altitude level where we're saying sepsis in general, multi-organ failure, being on the mechanical ventilator for a few days, a longer period. Those are the risk factors. But I don't know that a specific reason to get you in the ICU would be a higher risk factor.
Is there any study which says which are the organs which get affected first? I mean, does the person have to be drowsy and delirious? Can he get critical illness myopathy, neuromyopathy without going into delirium or without going into any renal dysfunction? Or are they happening later?
Yeah, I think these are all sort of risk seen as risk factors. And so I think about it statistically is that the more of these you have, the more likely you're going to get the ICU acquired weakness. And the less you have, the less likely. So it's not, I don't think of it as an all or nothing thing where if you have this one risk factor that you're definitely going to get it, or if you don't have that, you won't get it. It's just it's the summation of all the organ failures that I think add up to a higher risk of ICU acquired weakness.
But probably, sorry.
Right.
No,
No, I was
probably
gonna
one would be a little wary or skeptical, just as in diabetic neuropathy, somebody with diabetes and neuropathy, you don't want to diagnose unless the person also has some retinopathy, some microscopic albuminuria. Similarly, if there is no delirium at all, there is no renal dysfunction, I would be a little wary to call this critical illness myopathy, then you would think. And the other question which many people are repeatedly asking is, what about myasthenia? So how do you distinguish? And I want to ask you, how often have you picked up myasthenia presenting first time in an ICU because he's not getting off the ventilator, as against the person turning out to have critical illness myopathy? So how often does it happen that it is myopathy? Because usually it's referred as query myasthenia or something, and they want us to rule that out.
No, it's a great point. I don't know that I have specific numbers for you, but I think what you're getting at is you want to take a broad view of the patient of all possible neuromuscular disease. So for instance, sometimes we'll have someone who came in with difficulty breathing, they get on the ventilator. Why did they get there? Well, they had motor neuron disease that was unrecognized. And so if they got there via the ALS route, you don't want to say, oh, the motor responses are small, so this must be a critical illness myopathy, and they're going to get better. So you want to do really a thorough assessment. Start from the very beginning. Don't, and this is what your question gets to, don't make any assumptions that it has to be just critical illness myopathy, but be suspicious of other more generalized neuromuscular diseases like motor neuron disease, like neuromuscular junction disease. Those could be the pathways that got them in the ICU in the first place. So broad view. In some cases, you may want to do repetitive stimulation studies. You may want to do a more extensive EMG to look for signs of motor neuron disease, particularly if they have upper motor neuron signs. It's easy to go down that really narrow pathway of saying, oh, they just can't breathe, so it's phrenic nerve, or they're weak, so this must be critical illness, neuropathy or myopathy. But just take that step, and you all know this, but take that step back to look at, take a broad view.
Somebody also wants to know clinical pearls. So can you say as a broad, just to say that if the person doesn't have any ptosis, any ophthalmoplegia, any dysarthria or dysphagia, then the chances of myasthenia as the cause of getting off the ventilator are slim as compared to critical illness myopathy or something. Rarely you might be caught out and it might still be myasthenia, but I mean, you look at the other causes first and then think of myasthenia.
Yeah, I mean,
Satish, have you seen Satish myasthenia?
I was going to say that whenever it has been myasthenia, it has been pretty straightforward. Once you go and see, there is eye movement problem, there are other things. It's quite unusual to just have a ventilatory failure and limb weakness and it turning out to be myasthenia. Of course, like Dr. Roberts is saying, you have to look at it, but only once in a while. But the reference is always like that.
Yes.
This is myasthenia.
Yes, my chest physician has referred me at least 100 patients till now who are not coming off the ventilator. And once I got caught, I said, no. Once he sent the ACHR and it came positive, and later on the patient did turn out to have myasthenia.
But
Is that
that's the
often-
one you remember. So he's always going to send them to you to hope find another one.
Yes.
And then often they will have some complaints before they came to the ICU. They will have some weakness going on, and then they have landed up into the ICU with her on the ventilator.
One patient when I got cut out didn't have anything before, no symptom, nothing, and just presented first time with not coming off a ventilator with a critical illness, pneumonia or something. But I mean, most of the times you are not going to find myasthenia.
So there's a question of direct muscle stimulation. How you and when you do that?
Yeah, so there are some reports of doing direct muscle stimulation and recording. This is, I think, more of a research tool than a clinical tool. But basically what we do is we look at the distal third of the tibialis anterior. We take that part because there's no intramuscular axons. We don't want to stimulate axons. So we put we put half-inch bare needles, so like your EEG needles, into the muscle, 2 needles into the muscle distally in the tib anterior, and stimulate. And you can see a band of muscle fibers twitching when you stimulate. Then you take another pair of bare needles and put those into the twitching area and stimulate again and record from those other needles. So you're able to get a muscle fiber to muscle fiber response. You can also, while you're recording from those bare needles, stimulate the nerve, stimulate the fibular nerve at the fibular head. And the way we use this is, normally you should get a reasonably sized CMAP from stimulating muscle fibers and a similar response from stimulating the nerve. If you have a myopathy, then you'd get small responses from whether you stimulate the nerve or the muscle fibers. It's always going to be small because you don't have many muscle fibers there. If you have a neuropathy, the nerves, then the muscle fiber to muscle fiber response, that should be a nice normal size, but you won't get much when you stimulate the nerve because there aren't many nerve fibers. So that's a way that's been proposed to differentiate the neuropathy, the myopathy, and the normals, is to do this muscle fiber stimulation. There are some technical issues. It's not easy to do, and it's not always perfectly easy to interpret. So it's not something we always do clinically, but it is an available technique.
So there's a question from Dr. Nadir sir. Any role of neuroimaging, especially if the neuroexamination is incomplete? And how do you distinguish the critical illness myopathy versus cachectic myopathy? Any role of the scans actually. Do you do imaging? Especially if you're not able to do complete neurological examination.
But he wants imaging of the brain, spine,
brain or spine,
or muscle.
All, sir. I mean the spine and brain basically.
Yeah, I guess this gets back to sort of starting from a broad view and doing the history, including the pre-illness history, doing your physical examination. And certainly if you see upper motor neuron findings that make you think there's something going on at the spine or brain, that would be useful to do. But if your clinical presentation is really consistent with a peripheral neuromuscular disease, then I'm not sure you get much from doing the central imaging. And it's not easy to do in someone with, who's on a ventilator too. So again, that would go to taking that initial clinical view and seeing, what you think is in the differential, and then designing your test based on that.
So probably there's a last question. How long it takes to recover from ICU acquired weakness?
Yeah, another one that I wish I knew, and it depends. I think, and this is where we don't have enough data yet, but I think if you have a primarily or only myopathy, there we're talking in the few months range. And there's not a lot of data on this, but the little data that's out there is few months that you may get some recovery. The polyneuropathy is worse, and there we're thinking many months, year or more, or maybe not get a complete recovery. So the polyneuropathy is not as good an outcome And there you're looking at a prolonged debility. And just thinking about this all in the setting of COVID-19, I think we're going to be seeing a number of patients with ICU-acquired weakness. Now, not your person who just gets mild symptoms, but the person who's been very sick in the ICU. Those people are likely to get this and have a prolonged debility. So even though we save them acutely, they may have a prolonged disability out in the community for quite a while afterwards.
Larry, which is the organ, the muscle or the nerve, which is the more sensitive one? That means if you take percentage-wise, which ones have, out of 100, how many will have only myopathy, how many will have both, and how many will have more toward neuropathy? Probably muscle gets affected first, and then if it gets worse, then the nerve will get affected.
Yeah, I don't have an exact number, but based on the muscle stimulation studies we were talking about earlier, we think that the majority of weakness that you see is more caused by the myopathy. Like you're saying, the muscle is probably more frequently affected. You could have both going on, but in terms of what's causing the weakness, there's a little bit of data, not as much as we'd like, suggesting that maybe the myopathy is the primary cause.
So do you get only respiratory muscle weakness without
No,
any limb weakness?
That's very unusual. Usually it's the limbs too, but you just don't know that the limbs are involved.
Would you be a little wary if the person has only neuropathy and no signs of myopathy?
No, I see that. We do see that. And again, it's some of that might just reflect our ability to detect the myopathy. That because I mentioned that one study where people were not overtly weak, but if you do the nerve conduction studies, you will see abnormalities. So some of that is just the difficulty of detecting the myopathy or the neuropathy. They might have it, but we just might not be smart enough to pick it up.
Sir, there is a question of ICU-acquired weakness after cardiac arrest. There is no sepsis, but the patient had a cardiac arrest and had subsequently developed ICU-acquired weakness. Is it different from patients who develop a sepsis and then ICU-acquired weakness?
I don't know. Not a big group that we see, at least in my experience, the cardiac arrest. Now, certainly you can get the hypoxic ischemic encephalopathy, and you can get other central issues going on. And if you're in the ICU and you develop ARDS and sepsis afterwards, then certainly that could be a cause. But I don't think that's a really super high risk factor.
Yeah, I mean, the brain is much more